Next, Dr. Ramamurthy sir does not need an introduction actually. He's been the scientific committee chairman of AIOS, one of the most successful ones, and then the past president, and so on and so forth. And he is speaking, he's a dear friend. He's going to speak on dealing with the unhappy, dissatisfied smile or Lasik patient. And please go ahead, sir.
Uh, Thank you so much, Gaurav, for this kind invitation to be a part of your course. I think I'm just going to be showing a clutch of situations. Residual power after any refractive surgery, one of the pain points for any patient as well as the physician. And once you have done a smile procedure, we have been doing smile for almost a dozen years now. And it's not just smile, but it's Clex today with multiple platforms that are available. And before the circle became available, it was essentially PRK that we used to do. We used a streamlight, and it is a continuous initial debridement of the epithelium. Usually we take the epithelial measurement and feed that inside, and the thickness of the epithelium is taken off, and subsequently the power is corrected. Usually the amount of power that is left over is quite small, and mitomycin C is invariably placed in all these eyes for a 0.02% for a period of 30 seconds. And with that, a contact lens placement, 3 days later the lens comes off. It used to work quite well, and I'm quite happy with the results. But then of course these patients have to undergo through the pain, irritation, discomfort for a night, which usually is concomitant with a PRK procedure. Then of course now we have the smile procedure. I'm not going to go into the details of how it is done, but it's a the smile cone is given to you by the company, and you can see that it works very well. Basically, it's converting the cap of the smile procedure into a flap. So the advantages of having a very minor incision is lost, and you are having again back to almost a 300-degree incision. But it's the advantage of this is a painless procedure, and as far as the patient is concerned, it's a little more comfortable. But we were getting excellent results with PRK also, and in case it's just about a 0.5 diopters which is bothering the patient, as Dr. Sonu also mentioned, I would not hesitate even today to go ahead and do a PRK, simply because I don't want to lose the benefits of having done an initial smile where I could do the entire surgery with using a very small incision. Coming to the more important aspects which make the patient unhappy, like a retained lenticule segment. This was a walk in the park case, minus 1.5 diopters of spherical error in one eye, and minus 2, and post refractive surgery on the first post-operative day. She was a young college girl, and she was extremely unhappy. Minus 2 with minus 3.5 diopters of cylinder is the refractive error that she had. Fortunately, the other eye had done well, and actually she had the lenticule was taken out in fragments, and my colleague thought that she had taken out the entire lenticule, but this was the refractive error. And on topography, which was done, mind you, this was done on the first post-operative day. You can see this classical bow tie over here, which corresponds to the amount of refractive error that is there. And then, so we decided that it could be a fragment of retained lenticule. Decided to go ahead and try to remove this, and you can see that the initial opening opened up, and usually it's stuck onto the back of the cornea. Since we could not visualize this, we have subsequently published on this also. We are using diluted triamcinolone acetate, and immediately on using this, you can see this getting nicely demarcated over here. This is actually the lenticule fragment, which is right there in the center cap, and that's being peeled off, and that's being brought out, and then subsequently you can wash this off. I think using this diluted triamcinolone is a good tip, in the sense that it delineates any lenticular fragment that's left over quite adequately. And this is the topography. You can still see some amount of irregularity, but the bow tie that you saw completely disappeared. And the first day post-op refraction itself, after the removal of the lenticular fragment, was 6/9 with a fairly clear cornea. Obviously, the triamcinolone in the eye also would have helped to reduce the inflammation. This is that first one I showed was my own case, rather done by a colleague, and the eye hand took out the fragment. But this was a case which came from elsewhere, not referred to us, but the patient had been following with the primary surgeon for some time, but was very unhappy with the outcome. And this was the primary refraction according to the records, that minus 2.75 and 3.75. Left eye had done well, but right eye, uncorrected visual activity was 6 by 36 and best corrected visual activity was just 618. And my optometrist recorded a very irregular reflex on refraction. And as you can see here, the multiple pointers, we could not get the full history. Whenever you have faced with a situation like this, it's always a good idea to look at the primary surgery video in its entirety, and very often you can find out as to what exactly went wrong. But in this case, we did not have access to that video, and you can see the difference in the curvature. Here it's almost 45, while it's 40. And this area is suspicious, this is somewhat bulging forward. And if you, and this is what I wanted to highlight, 45.8 and 40. And you can see the epithelial, the stomal thickness map, and you can see is 542 and 491. So this is a significant difference. So this makes me suspicious that something might be left over there. And you can see in this anterior segment OCT that this is the possibly the lenticular fragment that's left over there. And just with the dilated examination, in a slit lamp examination, you see this rugosity, while this area seems to be quite clear. This is made me suspect that this could be an area where the lenticle had been left over. We are not the primary surgeon. This is running at twice the speed, and basically I am not using the transluminal acetate. I would have used it if I had not able to identify it. But my initial attempt to take out the lenticular fragment itself worked, and I could identify the lenticular fragment in the area where I suspected, and you can see that being peeled off from the posterior aspect of the cap, and that's the fragment which was doing the damage, which had primarily, whenever a patient has a problem like this, a refraction like this, it's a good idea to look for this and remove it if necessary. Oftentimes looking at the primary video, it also give an idea as to what went wrong. So this was the way the patient presented to us, and this is what subsequent to the removal of the lenticular fragment, you can see that the uncorrected visual acuity has improved to 6 parts with a fairly regular cornea. Ectasia as such is considered to be quite low compared to, especially if a case selection is quite appropriate. But then because of the huge number of CLEX procedures that are being done today, this is rearing up. This was a fairly high dioptric correction that was done in the year 2015. And today if I had a refractive error like this, I would go ahead and do a phakic intraocular lens, even though the smile is capable of handling this kind of a refractive error, simply because the stability of results that we get with a phakic lens. But at that time I had done a smile procedure for this patient, because the cornea was quite regular, the thickness was quite adequate, the bad D maps were also quite good, and this was in the left eye, which has a slightly lower refractive error but very similar thickness as well as bad D maps. And then the patient went off to the Middle East and then came back. Initially she had good vision, but that subsequently came back with a drop in vision, and you can see a very irregular cornea with a -6 best corrected visual acuity as 624 and a full-blown iatrogenic corrected ectasia which is inferiorly located. And very thankfully the left eye, which had gone exactly the same procedure for a slightly smaller refractive error, had maintained good visual acuity. We went ahead and did a Intax procedure with collagen cross-linkage for this patient. This is primarily the way it's done, and then the channel is created. At that time we are using the intralace for doing this, and then you can see the Intact segment being positioned where exactly it should be, and this is the subsequent collagen cross-linkage that's done. And basically with this what happens is that the cornea gets regularized, the decentered cone becomes a little better centered, and most importantly the refractive error, the best corrected visual acuity improves from 618 to 6 by 6. I'm not so bothered about the amount of refractive error that's left over, which has also reduced incidentally, but the more important aspect is the reduction, the improvement in the best corrected visual acuity which we are able to achieve. So we waited for a period of 1 year. Nowadays I would do it just for 6 months because I am quite comfortable with this. That was in almost 10 years back, and you can see that the difference map shows good stability of the the correction that was achieved. And at this time, we went ahead with a phakic intraocular lens implantation. And you can see that implant being put in place. So essentially, the patient presented with iatrogen keratoplasia post-smile. We initially handled with Intax and CXL, and after regularization of the cornea, we went ahead and did a phakic intraocular lens. That's with the post-operative picture, with the intact segment, with the phakic intraocular lens in place. And very surprisingly, 10 years of follow-up now, 5 years post-surgery and 5 years, the left eye has remained pristine and with no refractive correction at all. And it's the same, two eyes of the same patient. It's just that it's slightly less correction. So there's a lot that we do not understand about iatrogenic keratoplasia still. And this is just one index case for that. Epithelial ingrowth post-smile can be bothersome, especially it's quite rare compared to femtosecond flap-based procedures, but this can be disruptive, and especially if it's centrally located like this, the patient can be quite uncomfortable. So essentially what I'm doing here is to go ahead and debriding this, and we had waited for a period of about month's time, and when this was bothering the patient, I think I have topographic maps also. Then subsequently just debrided from the back of the cap as well as from the stroma. Here obviously you cannot lift up the cap, so we did use 20% diluted alcohol to essentially deal with whatever epithelial cells that were left over. And this is the post one day photograph. You can still see some haze over here, but then it has significantly improved. The visual acuity also improved quite well. Then DLK post-smile, it's again considered quite rare, but it can occur, and where you can see me going through the primary incision itself and giving a wash so as to wash out whatever debris that's there, because it was a grade 4 DLK with a drop in the visual acuity. It's essentially handled similar to what you do with a epithelial ingrowth. And epithelial defect, this was actually the patient said that she did have a minor trauma in the first post-operative day itself. It could have been induced during surgery also, but this is what we saw. Basically, we just patched up the eye, rather put a bandage contact lens, and within 3 days it healed up well. Apart from that, the usual complications like dry eye, infectious keratitis, transient light sensitivity syndrome, I'm not going to the details because I think I run out of my time, but then these have to be handled on their case merits. These are quite rare. Dry eye, of course, is possible, though the incidence is slightly less compared to flap-based procedures, but just in case you come across these symptoms, they have to be handled appropriately. Thank you so much for your kind attention.
Thanks, Dr. Ramamurthy, and that was quite an elaborate, talk on unhappy smile patients. I'll invite Jyot to take stage because we are running out of time, so I think I'll ask for a couple of questions and you can set up your presentation. I wanted to ask you, sir, and maybe you can join me here itself. Sometimes we have these smile patients whom you see that they look amazing and, everything looks perfect. You check their autorefs, they are almost plano sphere, plano cylinder. Everything is great and you think that, you've done a great job. And then the patient will say, but I'm not happy with my vision. And this is not just right in the beginning. Sometimes this will happen like even 3 months to 6 months down the line. And then you're at your wit's end, the epithelium healing is happening properly. You might just see a little bit of a, maybe slight decentration or something at the most, which you won't wonder whether it's accounting. Have you dealt with such patients, and then what do you do?
Yes, this is a problem that we are faced with all kinds of refractive surgery and cataract surgery also. Obviously, we'll look for dry eyes, and that's frequently a cause. And once you treat that adequately, it helps. Sometimes there's higher order aberrations that are left over that could be bothering the patient. It's also occasionally not meeting the patient's expectations. They are bothered by the glare and halos, etc., which obviously it's a young patient with a very large mesopic pupil that could also be a concern. But we do once in a while come across this.
Yeah, sometimes you try everything and then nothing